My name is Dee from the Wound Care Education Institute, and our program today is brought to you by the Wound Care Education Institute and made possible by a grant from Shield Healthcare. This event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. The Wound Care Education Institute was started by two nurses, Donna Sardina and Nancy Morgan. They had one goal in mind: to improve the management of wounds and ostomy for patients across the U.S. WCEI currently supports over 20,000 alumni through their certification courses in wound care, diabetic wound care, nutrition wound care, and ostomy. In addition, WCEI hosts the annual Wild on Wounds National Conference that's held in Las Vegas every year. During the conference week in September, there's an opportunity for those who wish to become certified to attend a certification course and receive WOW as a bonus. Details can be found at www.wcei.net. Before we begin the webinar, I'd like to run through a few housekeeping items. For those clinicians wishing to receive educational credit, you will receive an email from WCEI within 24 hours after the webinar with instructions on how to obtain your certificate. Please be sure to check your spam folder. If you have not yet downloaded the handout for today's presentation from your confirmation email, you may do so now by clicking on your sidebar. On-course learning is approved by the California Board of Registered Nursing. No CMEs are available for this event. On-course learning offers continuing education for hospitals, healthcare corporations, and organizations. Are you interested in learning about On-Course Learning's CE Direct continuing education platform for your staff or your faculty? Please select yes if you would be interested. If time permits, we will address questions at the end of the session. Feel free to enter your questions into the question box. As a reminder, you'll receive educational credits for this webinar. You must be logged into view the full presentation and view the slides. No credits can be awarded for those who do audio only. The planners of this course have declared no relevant conflicts of interest that relate to this educational activity. On-course learning guarantees this education activity is free from bias. And now I'd like to introduce today's speaker, Dr. Don Wollheim. He is board certified in general surgery by the American Board of Surgery. He has 25 plus years of experience in general vascular surgery and wound care, as well as extensive experience in medical legal consulting and teaching college advanced science courses. His teaching style includes emphasizing the fundamental concepts of wound care, incorporating additional visual aids, and utilizing clinical scenarios during his presentations. He is the lead instructor for diabetic wound certified courses and is also the editorial advisory boards, on the editorial advisory boards of Wound Care Advisor and Wound Central electronic journals. Welcome, Dr. Don.
Hey, thanks, Dee. I really appreciate that introduction. Today, what we're going to do is we're going to go through wound care. And initially, we'll start out with wound dressings in general. We'll then switch over to the wet to dry dressing, why it's being used, how frequently it's being used, and why it really should not be used any longer. But we would be doing you a disservice if we did not come up with alternatives to the use of wet to dry dressing, either as a debridement or in other phases of wound healing. Dressing selection is very complex. It should be sophisticated, should be as evidence-based as possible, but at least should be on standard of care. No matter where you practice, you will be held to national and international standard of wound care practice. Our goal is straightforward. It is simple. We want to heal the wound as quickly and painlessly as possible. And as simple as that statement is, it's very complex. In order to treat anything in medicine, be it medically or be it surgically, we have to identify the cause. And once we identify the cause, we have to correct the cause. Otherwise, we will not be successful. In addition, because every patient is unique, every resident's unique, we must provide them systemic support. We must maintain as physiology as possible, normal physiology as possible. Because after all, it's going to be the patient that's going to heal the wound. We're just going to set the stage for wound healing. So, considering with dressings, we may utilize a dressing as a primary or secondary dressing. A primary dressing is the dressing that first touches the wound. There'll only be one primary dressing, but it may be a powder, such as an antibiotic powder. It may be an ointment, such as an enzymatic debrider. It may be water, such as a hydrogel. It may be solid, such as foam, gauze. Secondary dressings are the dressings that are placed down on the wound after the primary dressing. And for lecturing purposes, as well as writing orders, I would write them in the order going from inside out. This is my primary dressing. This is my first secondary, my second secondary, my third secondary. We have to understand that not all dressings are indicated for all wounds. Otherwise, maybe all we need is wet to dry dressings. So what are the indications for utilization of a dressing? And importantly, what are the contraindications? And to understand this, we need to understand full thickness wound healing and the 4 overlapping phases. I know it's in your handout, but let's review it at this point in time. The initial phase of full thickness wound healing, which hopefully will just last a couple seconds, maybe a couple minutes, is a hemostatic phase. The main player of the hemostatic phase is those platelets. These are fragments that come off the megakaryocyte that is found in the bone marrow. Platelets, with the assistance of the coagulation cascade, will lay down fibrin strands. We will develop this fibrin plug. Platelets will also secrete growth factors, and growth factors will be basically chemotaxic agents. These will be agents that will get other cells, or get cells, molecules, oxygens to the wound for wound healing. The next phase of full thickness wound healing is we're going to clean up the wound bed. And this is where the phagocytes are going to do what they do best. A phagocyte is a cell that performs phagocytosis. It will surround, it'll ingest, and it'll digest foreign antigens because it has proteolytic enzymes within its cell body. It's capable of doing that. In general, the inflammatory phase should last about a week. The initial phagocyte coming out of the bloodstream is going to be the neutrophils. It'll be in the wound for about 1 to 3 days. And then the next phagocyte at the level of the wound is going to be the macrophage. However, when you do a CBC with differential, you do not see macrophages on the differentials. You see monocytes. And so the monocytes go to the wound, they will mature to the macrophages, and they will be there for the length of the time that we have the inflammatory phase. The macrophages also can secrete various chemicals, such as cytokines, to keep the wound healing process ongoing. If you're having difficulty healing your wound, though it does not look to be infected, for whatever reasons you cannot get, after a week, that nice beefy red raw hamburger and parents granulation tissue, which will characterize our next phase, then you are more than likely, your wound is more than likely in the inflammatory phase, and you might want to address it. The third phase, overlapping phase, is the proliferative phase of wound healing. Basically, to me, this is a wound that fills up with granulation tissue, it contracts, and it covers. The proliferative phase is going to last about 3 weeks. This granulation tissue is going to be the scar tissue. It's going to be the deposition of collagen. Collagen is a protein, actually it's 3 protein molecules wrapped around each other, known as a triple helix. And the cell that produces the collagen is going to be the fibroblast. Now, we're going to expect a lot from our wound in the healing process, so it's going to need a good blood flow there. And the cells of a capillary, we call these the endothelial cells, are now going to create these capillary loops that are going to go into this scar tissue. And this gives us that lumpy, bumpy appearance of granulation tissue. So what we're going to have is, with the proliferative phase, and we're going to have that granulation tissue being deposited. Now, the wound is going to get smaller in all dimensions, and a significant number of fibroblasts are converted to what's known as myofibroblasts. Myo is a prefix meaning muscle, and they will tug and pull on all the areas of the wound and to make it smaller. And now we can now resurface the wound. And the cell that's going to resurface the wound is going to come from the outside in, and these are the epithelial cells. Once that wound bed is covered with epithelial cells, it is protected from environmental contaminants. We need to do this as quickly as possible. In general, this proliferative phase will take about 3 weeks. But if it takes time to cover the wound, then the wound may become infected. And if it's a soft tissue infection, it may take 1 to 3 weeks to eliminate that. However, the longer we have this open wound, the greater the chance that the underlying bone can become infected with osteomyelitis, and that we may not be able to resolve in 3 weeks. We may not be able to resolve it at all. Your chronic, full-thickness diabetic foot ulcers that have been around for a good period of time, over 60% of them may have the underlying bone infected with osteomyelitis. Lastly, what's going to happen is the maturation phase. This is where the collagen fibers are going to realign. They're going to go from the weak collagen number 3 to the very strong collagen number 1 to increase the overall strength of the wound. It won't be as strong as what nature gave us initially, but it have about 80% of the strength. So we need to know these 4 overlapping phases of full thickness wound healing: the hemostatic, the inflammatory, the proliferative, and the maturation, in order to understand which products may be indicated and which products may be contraindicated during that period of time. Whatever we do, we want to maintain a moist wound healing environment. This is not a new concept. This dates back to 1962, when the United Kingdom surgeon, Dr. George Winters, did a study that showed that moist wound healing would heal up a wound twice as fast than a dry wound. With consideration of the dressing, we have to figure out what our goal is. Is our goal to debride the wound, get rid of the non-viable tissue? Is exudate a big factor, the amount of drainage? And we will relate and give value to the exudate by the amount, not so many milliliters of drainage over a period of time, but what comes off on the dressing when we change that dressing. So for example, when we change the dressing and there's no exudate on it, that's a dry dressing, dry wound. If we change that dressing and there's just a little bit of spotting of exudate on it, that's scant. And ideally, that's what we want, scant drainage, because that tells us we are providing moist wound healing environment. If we change the dressing and less than 25% of our dressing has exudate on it, that's a small amount of exudate. Change a dressing between 25 and 75% of our dressing has exudate on it, that's moderate amount of exudate. And lastly, we take off that dressing, greater than 75% of that dressing has exudate on it. That's considered large or copious amount of exudate. So we need to pay attention to the volume of the exudate. This may be one of our goals. Is bile burden a problem? Are we concerned about the fact that bacteria is at the level of our wound that's slowing down and maybe even stopping the wound healing process? Does the patient have pain? Is there bleeding with the dressing changes? So we have to figure out what our goal is, pick our dressing, and hopefully our dressing will attack multiple entities of our goals. Take in consideration this concept of frequency of changing your dressing. Every dressing has an inherent temperature effect on the wound base. Now, when you take a dressing off, that wound will be cooler for about 4 hours after you put that dressing back on. So it'll take about 4 hours to get back to the temperature when you take the dressing off and put the dressing back on. So like the photograph here shows a QID dressing change. If you change a dressing 4 times a day, that means 4 times 4, or 16 hours out of 24 hours, that wound bed is going to be cooler versus a dressing that you change once a day. Then only 4 out of 24 hours is that wound bed going to be cooler. This is very important. The temperature can be related to basically the selection of our dressing. The upper photograph, we show a gauze dressing. Gauze is our coolest dressing. That wound bed is going to be cooler under a gauze dressing than the lower photograph, which is a foam dressing, and this is our warmest dressing. Why does this matter? Because the cooler the wound bed is, we will now develop more vasoconstriction. That means there's going to be less blood flow going to the wound bed. There'll be less cells of repair going there. There'll be less oxygen for those cells of repair to function. There'll be less nutrients for our cells. And because we're trying to heal the wound, there'll be a creation of a lot of metabolic waste products. There'll be less waste products leaving from that area. So with vasoconstriction, and on this technique in this matter known as thermoregulation, it's going to slow down the wound healing, and even though you may be using sterile dressings, the wound's going to be at a higher risk of infection. Pay attention to what the manufacturers say. Now, they are the ones who've done the research. They're the ones who got FDA approved. It makes no sense to me to reinvent the wheel. They have done the studies. But as an ordering clinician, you can use off-label use from what the manufacturer says. As an instructor for Wound Care Education Institute, to me, using off-label use is substandard of care. I would always push for what the manufacturers say. For example, I do a review of a lot of wound care charts. A lot of times, sample is ordered. Sample is an enzymatic debrider. And the manufacturers, initially HealthPoint and now Smith & Nephew product, says that samples should be applied daily. I have reviewed records where they've shown sample being applied every other day to every third day. I wonder if that's going to affect the overall effectiveness of sample. Maybe that's why it's not working for you. We may use the dressing with various forms of adjunctive therapy. In the lower photograph, we see an Uniboot being applied. Now, underneath this Uniboot, there may be a foam dressing. Now, we want to leave the Uniboot on for about 7 days. But if the foam dressing only has a wear time of 3 to 5 days, then that dressing needs to be removed at 3 to 5 days. You cannot go out to the 7 days. We may want to use a antimicrobial dressing combined with a debridement. For example, you may want to use a silver dressing with Santal. Santal is an enzymatic debrider. The enzyme in it is collagenase. But Santal works over a very narrow pH range of 6 to 8. And it will be less effective anything that's taken out of that pH range. For example, if we use an acidic prep, that may take it out of that pH range. Heavy metals such as silver can make the Santal less effective because it's going to take it out of that very narrow pH range of 6 to 8. We have to look at the cost of the dressing. Now, if everybody just looked at the unit cost of a dressing, we would stop, because the cheapest dressings would be gauze, some saline, and some tape. Well, we got to look beyond the unit price. For example, if we have a gauze dressing, gauze-based dressing, such as wet to dry dressing, and we change it 4 times a day. Well, 4 times a day, somebody's got to go to the patient, take off the dressing, discard the dressing, put on a new dressing. And if this process of the wet to dry dressing is less effective, we may be treating that wound longer than if right up front we got a more expensive unit cost advanced dressing that we would leave on, not change it 4 times a day, but maybe change it every day to every 3 days, 4 days. But it heals the wound faster. So as it turns out, what you may believe and perceive as the most expensive dressing, because we can use it less frequently, have to apply it less frequently, and heals the wound faster, in the long run, may be much less costly than gauze, saline, and tape. So let's go into the wet to dry dressings. What actually is wet to dry dressings? What are we talking about? The definition of wet to dry dressings is a non-selective mechanical debrider. Let's break those terms down. Debridement is when we remove non-viable tissue from the wound bed. We will only do debridement in the inflammatory phase of full thickness wound healing. There's 2 main categories of debridement. Selective debridement is where we, in the process of removing the non-viable tissue, we leave the good viable tissue alone. There are 3 techniques of selective debridement. Non-selective debridement, where wet to dry dressing falls under, is where in the process of removing the non-viable tissue, we have to sacrifice some viable tissue. There are 2 techniques of non-selective debridement. One is mechanical debridement. That is where wet to dry dressing technique falls in place. In general, wet to dry dressing is we're going to apply sterile saline or water, moisten on woven gauze onto the wound bed. As that gauze dries out, it adheres to the surface of the tissue. We're going to remove it every 4 to 6 hours. The gauze should be removed dry. Do not moisten it. You want to firmly pull the dry gauze out. You want to rip it off the wound bed. Why do I use that term? It causes pain, can cause bleeding to the patient. It will pull off that non-viable tissue, but we have to understand, being non-selective, we may also pull off viable tissue. The technique is not standardized. Some practitioners will remoisten gauze upon removal. Well, actually, this is moist-to-moist dressing. I remember years ago, as a surgical resident, no gray hair, foolish individual, I got concerned when the nurses would take my wet to dry dressing order and would moisten the gauze before they took it off the patient. Yeah, I got concerned because that was not the wet to dry dressing technique. But you know what? They were smarter than I was. They were actually doing the patient a great service. There may be other solvents that are utilized other than normal saline. Some are listed in your handout. Frequency of dressing change varies. I know in the 70s when I trained as a surgical resident, we applied wet to dry dressings and changed it every 12 hours or BID. So what are the indications for wet to dry dressing? Remember, it's non-selective mechanical debridement. So it is only indicated on top of non-viable tissue during the inflammatory phase of full thickness wound healing. We're using it as a form of debrider. Any technique of non-selective debridement, such as wet to dry dressing, will pull off viable tissue in the process of pulling off the non-viable tissue. What are some of the contraindications to wet to dry dressings? Well, If we apply it on top of granulation tissue or wounds that are reepithelializing, they're not in the inflammatory phase. They're in the proliferative phase. And no form of debridement, be it selective or non-selective, should be utilized in the proliferative phase. It's only intended for the inflammatory phase. Why is this a big issue? I mean, is this a rarity? Not really. Your handout gives you a reference to a review, retrospective review of 202 patients between 2002 and 2004. This occurred in Florida. And basically, it was a survey to find out how frequently was wet to dry dressings ordered, how frequently were other dressings ordered, who ordered it, and was it ordered correctly? Well, the wet to dry dressing technique was ordered 42% of the time. There was no other dressing that was ordered more frequently than wet to dry dressing. In fact, there was no other dressing that was ordered greater than 10% of the time. Most of the wounds were treated surgically, which makes sense to me, having trained as a surgeon, because this is where it was indoctrinated into us about the wet to dry dressing technique. And it also makes sense to me that the surgical specialists will prefer wet to dry dressings. Now, here is a big factor where it is a problem. In their retrospective review, mechanical debridement, such as wet to dry dressing non-selective debridement, was not clinically indicated in about 80% of the populations. They were using this on the proliferative phase, on top of granulation tissue, on top of epithelializing tissue, 80% of the time. So not only is it used most frequently of all dressings, but it was used incorrectly more times than not. What are some of the disadvantages of wet to dry dressings? Well, being non-selective, it can remove healthy tissue at the same time. It can re-injure the wound. The patient may have pain with the dressing removal, bleeding with it. You may believe that your wet to dry dressing is a sterile dressing. You put down a couple layers of sterile gauze, moisten it with either sterile saline or sterile water, and secure it in place, let's say, with tape. Well, studies have shown that bacteria are able to penetrate 64 layers of gauze. So unless you put down 64 layers of gauze on top of your wound bed and then put tape on it, it's not a sterile dressing. Why? Where's the tape found? It doesn't come out of a sterile container. It comes out of somebody's pocket, a drawer. And so, though you perceive that what you're using is a sterile dressing, it is not. Gauze can unravel. Gauze may have strands of gauze on it and being left in the wound bed. Now, surgeons, these particles are non-absorbable, and they may get within the wound bed, very similar to patients that you've had who have non-absorbable sutures and have stitch abscesses that drain constantly or on and off over a period of time, and it will drain until you cut out that suture. Same thing may happen with these gauze strain. They'll form a granuloma and they may get infected. I already talked about the problems with cooling of a wound. What happens with cooling of the wound, we have vasoconstriction. And anything that causes vasoconstriction can slow down the wound healing because there will be less blood flow going to the wound bed, less cells of repair, be it neutrophils, macrophages, or even fibroblasts, may have less oxygen going to the wound, may have less nutrients going to the wound, and may have less waste products leaving the wound. cooling of the wound leads to this vasoconstriction. With less oxygen going to the wound is hypoxic. But we're expecting a lot from our cells to heal up a wound. We're expecting our neutrophils, our macrophages, to perform phagocytosis, to surround, ingest, and digest foreign antigens because they have proteolytic enzymes in their cell body. We expect our fibroblasts to lay down these triple helix protein molecules known as collagen. They're going to need a lot of energy. And if you remember the carbohydrate cycle, at the very end, we need oxygen in order to produce large quantities of ATP, which is our energy unit of a cell. Now, with this vasoconstriction, our white blood cells may be inhibited getting to the wound bed itself. So there may be less neutrophils, eventually less macrophages. So their phagocytic activity may be less just because of numbers, or because of lack of oxygen, they may not be as effective, which means that the bacteria could win. It may increase the bioburden at the base of our wound. Physiologically, in a cold environment, that hemoglobin molecule, remember it's two pairs of protein with 4 heme units. Each heme unit is able to transport 1 oxygen molecule. In a cool environment, this hemoglobin molecule, even if it gets to the area, may hold on to the oxygens over a longer period of time than in a warmer environment. With this cool environment, with this hypoxia, and this vasoconstriction can impede the wound healing and increase the wound's susceptibility to infection. Here's an interesting concept. The thought was that removing a dry dressing may serve as a vector transmitting bacteria to the patient in the nearby area and the healthcare providers who's coming to take care of them. Several years back, the British literature was questioning, because remember, they're under socialized medicine, or a form of socialized medicine, whether or not their clinicians should wear neckties when they make rounds. Thinking that the neckties, when they change a dressing, the bacteria get onto their neckties, they go to the next patient and goes onto the next patient, they get some more and go on to the third patient. And they were seriously considering this. And a couple months back, one of my students in a WCC course was from the United Kingdom. And she assured me that this was implemented in the United Kingdom. They took it one step further. Not only should their clinicians not wear neckties when they make rounds, but they should have short sleeve shirts. They don't have the long sleeves, so the bacteria can get on it and be transported from one person to the other. A couple years back, I saw this in the US literature, one of the throwaway surgical magazines. I didn't think anything was going to happen with it because, we're not really socialized at this point in time. And as yet, I've not heard this being an issue. If you're going to use wet to dry dressings, it is a non-selective mechanical debridement. That being the case, it should only be utilized in the inflammatory phase of wound healing. It is any form of debridement, including wet to dry dressing, is absolutely inappropriate in the proliferative phase of wound healing. If it's used in the proliferative phase of wound healing, it can disturb the deposition of collagen, areas that need ingrowth of blood vessels, such as angiogenesis, as well as reepithelialization of the wound. Several times in my chart reviews, I have looked at patients who showed up at the clinic, the wound clinic, and the clinician noticed that the wound bed was 100% granulation tissue. And what they did was, and I couldn't understand the logic, and I still don't, what they did was they sharply debrided some of this granulation tissue down to bleeding. Well, sharply debridement should only be done in the inflammatory phase, not the proliferative phase, like they're using it. So ultimately, used incorrectly in the proliferative phase, We're going to slow down the wound healing process, which means that that wound is not covered as quickly, so that wound be more subject to environmental contaminants. So we may develop that soft tissue infection and a higher chance of developing that underlying bone infection with osteomyelitis. There's that incorrect perception that just because we're using gauze, saline, and tape, this is the cheapest way of healing wounds, and we should use it. Got to look at the big picture. Take into consideration the frequency of application and how soon that wound is healed. If it's healed much more quickly and less frequently applied modern day wound dressing, then that cheap gauze, saline, and tape may be very expensive, because we're going to have moisture in that wet to dry dressing. As in the lower photograph, we may have maceration around the wound edge. What does that do? That actually increases the cross-sectional area, not necessarily going from edge to edge, but overall increases the wound itself. So, should we consider wet to dry dressing as a non-selective debrider, or its utilization in the proliferative phase of wound healing as substandard wound care? We at Wound Care Education Institute think very positive that it should be considered a substandard wound care. But a lot of the regulatory people, including CMS, believe that wet to dry dressing utilization is substandard and should be eliminated. So why is it still being used? We showed the studies from 2002 to 2004. It was ordered 42% of the time, more than any other dressing. Well, why is it still being ordered so frequently? Well, the clinicians' training and their experience. Got to take that in consideration. When I trained in the 70s and practiced surgery in the 80s and early 90s, at that point in time, we really didn't have many options. We really didn't have options. We were trained by our chief residents to do wet to dry dressings, and they were trained by their chief residents. And this may go all the way back to Halstead. I don't know. But this is what we were taught. We've all had experience of healing wounds utilizing the wet to dry dressing technique. But at what cost? We should only utilize it, or could consider utilizing in the inflammatory phase of full thickness wounds. It is a mechanical debrider. The idea that gauze, saline, tape is cheap is true. But in the long run, is it true the most cost-effective way of healing the wounds? We really, in the 70s, when I was trained, 80s, when we were applying it a lot, really didn't have a lot of this negative knowledge about wet to dry dressings. We knew it hurt the patient. Our nurses knew that, because quite often they would put saline on it or water on it before they took it off, and making it a moist dressing for the sake of the patient. They were right. I, as the ordering clinician, was wrong. At that time, we knew it caused pain, it caused bleeding. Didn't really know much more. At that point in time, what advanced wound care dressings did we have? Probably a handful or two. Now, together, there's over 2,000 to 3,000 dressings out there. A lot more available to us. So is there enough evidence to exclude wet to dry dressing as mechanical debridement for the 21st century in wound care? I hope I made the case that the evidence supports yes. Definitely if you're utilizing it in the proliferative phase of wound healing. But I think I made a good case that it should be considered substandard when you're utilizing it in the inflammatory phase as a non-selective mechanical debrider. Should we consider this an all or none proposition? I believe the answer is yes. Change is hard. We all have to go through change, but is it in the best, is it best for our patients? Let me give you an analogy. Let's look at the open versus laparoscopic cholecystectomy. I trained in the 70s. The only thing we did was the open cholecystectomy. All the 1980s, the only way we removed gallbladders was with those big right upper quadrant incisions to take the gallbladder out. And that was all in the 80s. It wasn't until the end of the 1980s, early 1990s, that they started introducing laparoscopic cholecystectomies in this country. I was out in practice at that point in time. And I didn't learn this in my residency, and a lot of us took what I call weekend courses. We go to a day and a half, we understand how to utilize this technique of laparoscopic. We operated on pigs, we'd go back, and I'll tell you, it was really soul searching early on to do this lap chole. It was, we're all thumbs doing it. Because as general surgeons, we did not do laparoscopic procedures per se. I honestly don't think during my surgical residency, 5 years, I ever did a laparoscopic procedure except with working with a gynecologist. So this was tough. But what happened in the early 90s, by mid 90s, we heard from the patients. They loved it. With an open cholecystectomy, we can anticipate the patient being hospitalized 3, 5, 7 days with a lot of pain for 1 to 2 weeks. With laparoscopic, maybe a day, couple days worth of pain, they were home the next day or 2 days. They were back to work a lot sooner. The insurance industry thought that this was a good idea. We still have to know how to do open cholecystectomies under certain circumstances, but in general, laparoscopic cholecystectomy should now be considered the standard of care versus open cholecystectomy. I would be doing you a great disservice if I didn't give you other options in regards to what can we do in the inflammatory phase other than the non-selective mechanical debrider, known as wet to dry dressings. And what do we have in the proliferative phase that when it was used incorrectly over granulation tissue, epithelializing cells? So let's first go through the debridement options. We're going to go through the first 3 will be the selective form of debridement. Remember, they're only going to remove non-viable tissue. Autolytic debridement, it's selective debridement. The body uses its own enzymes. What it does, it uses the proteolytic enzymes that are found in the phagocytes and neutrophils and macrophages to get rid of the foreign antigens. We're going to need to maintain a moist environment. So if the wound bed's dry, we need to add moisture to it. The only category we're going to talk about is the hydrogels, 90% water. If they have exudate, we got to get rid of that excess exudate. We may use a foam, we may use a hydrocolloid. If that doesn't handle the exudate, we may go up to an alginate. If that doesn't handle the exudate, we may go up to a hydrofiber such as Convitex Aquacel. Autolytic debridement is the slowest form of debridement. With that taken into consideration, in and of itself, it's not recommended for infected wounds. Another form of debridement that's selective is enzymatic debridement. The enzyme we utilize today is collagenase. The trade name is Santal. It's collagenase in petroleum. On the photograph, you see it's a Health Point product. It is now a Smith-Nephew product. It is selective. It's not harmful to healthy tissue. It is the only enzyme we have. We believe it's overall fast, but we don't have any other to compare it to. A lot of us grew up with Accuzyme and Panafil, where the enzymes were papain, urea, but that worked over a much broader pH range than the Santal. For Santal to be effective, it needs to be applied once a day. Just like autolytic debridement, enzymatic debridement should only be utilized in the inflammatory phase of full thickness wound healing. And lastly, biological debridement. This is the last technique of selective debridement where only the non-viable tissue is removed. This is where we apply live maggots to the wound bed. On the photograph, these maggots have been down there for a period of time. They're swollen, they're brown in color. I don't know if you can see it from that container, but there's little white streaks down there that can't tell it's moving, but that's what the maggots look like coming out of the container. 24 hours later, they can get rid of this non-viable tissue. It will stimulate the fibroblasts in the next phase of wound healing, the proliferative phase. We're going to leave them on the wound for 1 to 3 days. Multiple applications are usually going to be required, maybe 2 to 6 in number. So those are your 3 selected debridements: autolytic, enzymatic, and biological. All they will go after is the non-viable tissue, but even so, we should only utilize them in the inflammatory phase of full thickness wound healing. Non-selective, this is where getting rid of the non-viable tissue, we sacrifice some viable tissue. Mechanical debridement. Remember, this is where wet to dry dressings fell into place. This is where we're going to use external force that's great enough to separate or break the adhesive forces in necrotic tissue. Hydrotherapy would include such things as the ultrasound debrider that you see in the upper photograph, or whirlpool in the lower photograph. It's going to provide a certain amount of pressure to the wound bed. And this pressure is going to be measured in PSI, pounds per square inch. If you provide more pressure than 15 PSI, it can drive the bacteria from the surface into the depths of the wound. Towards the end of the 1970s, a lot of surgery departments in the hospitals picked up a lot of Teledyne water picks. I mean, this was convenient. You had the reservoir to put your solution, and you have this gizmo to squirt it right on the wound. And it could go by the bedside. Didn't work well. Why? The pressure it submitted was 80 PSI. It drove the surface bacteria into the depths of the wound. Sharp debridement is the last form of debridement. It too is non-selective. Sharp debridement to be performed correctly needs to be performed in a sterile technique. Sterile prep, sterile drape, sterile instruments, and a sterile dressing on at least for 24, preferably 48 hours post-procedure. And anytime you change that dressing within the first 48 hours, you should use sterile technique. It can be performed at the bedside or in a clinic. That's known as sharp conservative, or in the operating room, sharp surgical. If there is an underlying concern underneath that non-viable tissue that there may be an infectious process ongoing, I would initially go to sharp debridement, because you want to know right away what is going on. And if something needs to be drained, you want to establish drainage. So I gave you 5 techniques of debridement. 3 are selective: autolytic, enzymatic, biological. 2 are non-selective, such as mechanical, where wet to dry used to fall under, and sharp debridement. All debridement techniques should be performed only during the inflammatory phase of wound healing. Well, what about the proliferative phase? Remember that study? About 80% of the time, wet to dry dressings were used in the proliferative phase of wound healing. Well, I got to give you some idea of what you can use instead of the wet to dry dressing. So let's go through the dressing categories, and we'll go from the least absorptive to the more absorptive. And the only dressing category that'll donate moisture is a hydrogel. This is 90% water in a gel base. If you have a dry wound, because remember, we want to live by that moist wound healing principles, you want to add moisture. It comes in 3 physical properties as shown in the upper 3 photographs. On the far right, that's amorphous hydrogel. It comes out as a gel. In the middle photograph, the person's holding a hydrogel sheet. And the lower photograph, that is impregnated hydrogel. Applied, if there's any necrotic tissue, it'll help soften that tissue. It'll maintain that moist environment. We may mix it with various antimicrobial components, such as silver. Example, you can see there is Silvermed. Silvercept is also an example. It may come with hypochloric acid. It may come with sodium hypochlorite, such as anisept. You have several trade names in your handout. It is the best option to be utilized on normal body parts. For example, if you have a fascia, you want to maintain moisture to it. Tendons, ligaments, muscles, cartilage, bone. We want to keep it in a moist environment because of the fact, let's say a tendon dries out and breaks. Because it has a poor blood flow there, it's going to require surgical approach to get that tendon functioning again. You may even consider utilizing it on granulation tissue, a moist environment. Transparent films, they absorb no drainage whatsoever. We can use it from protection against friction because it gives a very slick surface. Bacteria from the outside cannot penetrate below the film. Because it absorbs nothing, any moisture there is going to stay there, and this will stimulate a moist environment. It may be left in place for 3 to 7 days. It's going to waterproof the underlying tissue, so fluid from the outside can't get in, fluid from the inside can't get out. To me, it is the ideal operative tape. In the upper photograph, you see that they've laid gauze down. Now, when you use a transparent dressing correctly, you should defat the skin first with alcohol and then put a skin sealant on the skin where the transparent film will touch. A skin sealant is a solution of basically a polymer and a organic solvent. The organic solvent evaporates and leaves that plastic behind. Why is this ideal? Well, if you look at that photograph, there's not 64 layers of gauze there. But the transparent dressing comes out of a sterile container. That, to me, is why it's the ideal operative tape. We have to understand that transparent film is contraindicated over infected wounds. Contact layers, we don't look at it for its absorptive capabilities because fluid tends to go through it. We look at it for protecting the wound bed. It's going to protect the wound bed from trauma. What type of traumas? Maybe just a dressing change. It will always be first applied to the wound, so it's always a primary dressing. One of the mechanisms why it works is you change it very infrequently. Some you leave on for 5 to 7 days. If you utilize negative pressure wound therapy, we'd strongly recommend that you use a contact layer as a primary dressing, and then put your foam or A&D gauze on top of it. This may prevent the granulation tissue from eroding into the foam. And then now when you change that dressing every other day, you don't rip your granulation tissue, leading to pain and bleeding. Collagen dressings are truly only meant for the proliferative phase of wound healing. What they're going to do is help the appropriate deposition of collagen in the wound bed. Now, some of these come from cattle, some of these come from pigs. You should be concerned of religious sensitivity of your patient or resident. If they're Hindu, the cow is a sacred animal. If they're Hasidic Jew, even if you use cow, you have to understand that this was not harvested under rabbinical supervision. They may not like it. So collagen, it should only be used in the proliferative phase of wound healing. Hydrocolloids have more absorptive capabilities, or some absorptive capabilities. It can protect the wound from incontinence and intact skin. In fact, if you recently had a wound that is healed and completed a proliferative phase of wound healing, then I would consider putting a hydrocolloid on it to splint it for a couple weeks. Change it per product manufacturer. It provides the best insulation because this is our only dressing that is totally occlusive. Nothing from the outside goes in, nothing from the inside comes out. When you remove the dressing, there may be an odor, but this is not a clinical odor because that odor goes away when you clean the wound the first time. But there may be a residue left behind. And this can be a problem if you have a deep tunnel or significant undermining. Like the transparent dressing, hydrocolloids are contraindicated over infected wounds. You may place it under an Uniboot, under a venous insufficiency wrap, or under a total contact cast. Just be sure that the wear times match. If you're having trouble getting an airtight seal when you're utilizing negative pressure wound therapy, as seen in the lower photograph, you can actually window pane the wound and now apply your negative pressure wound therapy, and the transparent film may adhere to that better than it did to the hydrocolloid. I'm sorry, than the skin itself. Now, where the hydrocolloid should not be utilized over infected wound, a foam dressing can be, and it is our warmest dressing and absorbs about the same as a hydrocolloid. We can use it to control scant to small amount of drainage. What does that mean? Less than 25% of your dressing may have exudate on it. Remember, it's our warmest dressing, so there'll be less vasoconstriction under a foam dressing than under any other dressing. If you have hypergranulation tissue, where you have the granulation tissue going above the plane of the skin, you need to knock that down so the reepithelialization can occur. You can do that with a foam dressing with slight compression on it. Like the hydrocolloids, you may use it under an Uniboot, venous insufficiency wrap, or total contact cast. Not only does the wear times have to match, but make sure you don't have too thick of a dressing. Otherwise, the dressing itself may act as a pressure point. They may come with various antimicrobials or surfactants, cleansing solution in it. In the lower left photograph there, that pink dressing, I believe, is a trade name Polymem. And Polymem is a foam dressing where the product manufacturer says because it has a surfactant in it, you don't want to clean in between dressing changes. You just take off your old Polymem and put your new Polymem on. What's a surfactant? It's a solution that has both hydrophilic, water-loving, and hydrophobic, water-hating properties. Together, they'll loosen up the bacteria, the debris from the wound bed. Now, where the hydrocolloid, which absorbs about the same as a foam dressing, cannot be used over an infected wound, the foam dressing can be. If you need more absorption than what a foam dressing is, you may go up to an alginate. These are dressings made from seaweed. They may have calcium and sodium fibers. They're used to control moderate to heavy exudate in the wound. What's moderate? 25 to 75% of the dressing that you take off has exudate in it. Heavy is more than 75%. It's going to maintain a moist environment. When there's enough exudate, it will form a gel. So anything that forms a gel will assist with autolytic debridement. It has hemostatic properties. And how it has hemostatic properties, the calcium alginate donates calcium ions to the wound bed. Now, calcium is utilized in the coagulation cascade, and that may assist with the hemostatic properties. At the bedside, if I do a sharp debridement and somebody is going to go back on aspirin or Plavix, I will make my primary dressing an alginate because it's readily available in a long-term care facility. However, because it donates calcium ions to the wound bed, we worry about any dressing that donates to the wound bed in the pediatric population. The calcium alginates are contraindicated in that population. It's not for use on dry wounds. How do you know it's on a dry wound? You don't get that gel-like characteristic. Some people use it in combination with a hydrogel. That makes no sense. If you have enough exudate, the alginate should function just fine. The hydrogel, what's going to happen is it's going to be absorbed by the alginate, and you're going to decrease the absorptive surface areas of your dressing. Composite dressings, to me, are your ideal operative dressings. Not only does your dressing come out of a sterile container, but also does your adhesiveness. And it can absorb anywhere from mild to heavy amount of exudate. Wound fillers, if you need more exudate control, consider wound fillers. These are meant to fill wound cavities. They come in various physical properties. Your specially absorbers, as one of our other WCEI instructors called them, these are your big sucker uppers. These are multiple layer dressings, highly absorptive fibers. In this category, the hydrofibers fall. This would be Aquacells, or Convitex Aquacell or Aquacell AG. Some of my students believe that Aquacell is an alginate. It's not. When it gets moist, it'll look like an alginate. However, it is not an alginate. It is a multiple layer dressing. It absorbs more than the alginate. Some can have antimicrobials in it, such as Aquacell AG has a silver ion in it. So in summary, wet to dry dressings have been employed by generations of surgeons over many, many decades. They work at the time they work. However, at a cost to the patient. We did not have that many options. And if we're utilizing them inappropriately over a proliferative phase, we maybe did not understand the advanced wound dressings. So always strive for moist wound healing. This has been in existence since 1962. Wet to dry dressing is substandard of care. It's not that Wound Care Education Institute believes so, but multiple regulatory people, including CMS, believe that. Wet to dry dressings should be completely abandoned, not only in the inflammatory phase, but when it's absolutely contraindicated in proliferative phase. We understand it's hard to adopt to new technology in any areas of medicine. I remember when we first did those laparoscopic cholecystectomy, I was hoping that would go away. This was tough to learn. We know it's extremely difficult, but let us help you. In your handout, you have a way to reach WCEI. You even have my email address. I would love to help you get through your learning curve utilization of some of these other dressings and techniques. I'd like to thank you for attending this webinar, and at this point in time, I'm going to turn it back over to Dee.
Thank you all so much for attending today's webinar. This concludes the continuing education portion of this webinar course, and we'd like to send a special thank you to Dr. Dawn Woolheim for such a wonderful presentation. At this time, if you guys have any questions, feel free to answer them or enter them into the question box, and Dr. Dawn, if you're willing, we're going to have you answer some of them.
Depends how hard it is.
Alrighty. There was one question that several people asked here during the webinar, so I'm going to go ahead and ask you this one. What advice do you have for attempting to educate our physicians on the disadvantages of wet to dry dressings? Even in my pediatric hospital, wet to dry dressings are often ordered specifically by our plastic surgery and cardiosurgery departments. Going to them as a wound nurse, I'm often ignored.
Well, welcome to my world. I'm usually ignored too. What I'd suggest that you do is let them know about this webinar. Shields Healthcare is going to keep it on their website for a period of time, and they can learn from it. If you felt this was valuable information to you, give it to them. Give them that idea. Give them my email address. I would be delighted to communicate with them anytime. That's what I love doing, is teaching.
Awesome. Okay, so next one. When is it appropriate to utilize Dakin solution soaked gauze packing?
Well, Dakin solution is basically a solution that has hypochloric acid in it. Hypochloric acid is an antimicrobial, and it's unique because hypochloric acid is only effective against gram-positive organisms. For it to be effective, it needs to be applied twice a day. One way I used to do it would be time compresses. Twice a day, I'd have them put down a gauze soaked with Dakin solution for 15 to 30 minutes, twice a day, and then use my other dressing on top of that. That is different from something known as sodium hypochlorite that you can find in Anisette. Sodium hypochlorite is effective against both gram-positive, which only Dakin's is, such as staph and strep, but also gram-negative organisms. So you need to keep in mind that Dakin's is only effective against gram-positive organisms when you have staph and strep. It would not be effective against Pseudomonas, E. coli, or other organisms that may be gram-negative.
Right. Next question. If we continue to use this dressing type so often in practice, does it mean we're getting good results, or is it just because insurances are not always willing to allow physicians to change various other methods, dressing types? I think they were referring to
The wet to dry.
Right.
Yeah, well, you have to define good. To me, utilization of wet to dry dressings is not good results when you have so many other options, less pain, less discomfort, and healing the wound faster. The insurance companies are going to push it. The regulatory people, Medicare is going to push it. So it's not necessarily that you're getting good results, you're getting results, but that you may be able to get better results. You may be able to heal the wound up faster with less discomfort of the patient using some of these advanced techniques or other techniques of debridement.
Okay, next question. When placing a contact layer under an NPWT dressing, must the wound bed be 100% granulation tissue, or can you place it over bone or muscle?
That's a good question, and that is one that I would discuss with my vendor. My understanding, and this is totally 100% shooting from the hip, yes, you can. But I would discuss it with the vendor because in general, negative pressure wound therapy, at least the type that we're talking about right now, is intended for the proliferative phase of wound healing on top of granulation tissue. Your vendors may have a better idea what happens when you apply it on top of bone, on top of muscle. And if you can use it, then I would ask them, can you use a contact layer?
Okay, let's do one more question. Now's
the zinger, right?
Yeah.
Now you're going to get me. Make it simple. I'm an old man.
How would you handle a wound that has scant drainage, requires packing, but exhibits granulation?
How would I handle a wound that has scant drainage, requires packing, and has granulation tissue? Hydrogel. I'd use a hydrogel type of packing in it, because as long as you have that granulation tissue, you want to make sure it stays in a moist environment. I'd use a hydrogel as my primary dressing, but my secondary dressing would be something that can absorb the fluid that is going past the hydrogel. Maybe use a foam dressing on top of it. I would start out with that.
Okie dokie. All right, that's all for questions. Thank you all so much again for attending. Have a great day.
Thank you, everybody.